the questions I get from patients all the time in clinic is which approach is best to get into the hip, and is this approach my friend have better than the other approach, and a little bit of explanation. So I want to go through this so we can understand what are the different approaches to the hip, why I have my preferred method to go into a hip, but there is a lot of different ways to get there, and ultimately hip replacement is a very successful operation regardless of how you get in there. I like to try to mitigate some of the problems with each approach, and I'll go through why I like the one I do. So the hip, and I have this Plato model here, is comprised of a lot of hip flexors. So you have a muscle that is the main stabilizer of the hip, the gluteus medius and minimus, which is we call the abductors, and its job is to abduct your leg away. And in fact, with people with hip arthritis, 20 to 30% of people have tears where this is off the bone, and that shows up as pain on the outside of the hip. So people point to the outside of the hip and say, my hip hurts here, and typically they have an injection for what we call trochanteric bursitis, but it can be from an underlying tear of that muscle. Next is called the TFL, or tensia fasciae lata. Then you have the sartorius, which actually comes up from here. And then on top of that is your lateral femoral cutaneous nerve, which gives you sensation over the front part of the thigh. And then you have your rectus down low, and your hip flexor or psoas come in and attach to the femur that goes over the brim. In a direct anterior approach, we take advantage of the Smith-Peterson interval, or the Hueter approach, by coming in an incision about this big down the skin, and we come right on top of this muscle belly. We don't cut any muscles coming into the hip, and we pull this to the side with a special retractor, and this identifies the rectus muscle below. And then we take another special retractor and we pull these apart that now bring us directly into the hip joint. The benefits of this approach is that you don't detach any muscles while you're coming in, and it is a more stable approach when it comes to dislocation after surgery. The disadvantage of this approach is that, one, as you can see how close this nerve comes in, even when this nerve is not injured, and it very rarely is, it gets really pulled hard to then get into this hip joint. And so people can get numbness up to 20% of the time in this area. Number two, which is the more concerning thing to me, is that all of these on this side are your hip flexor muscles. So it's what flexes your hip up, it's what you do when you sit. And in a recent paper, upwards of 20 or 30% of people after direct anterior have some mitigating symptoms of hip flexor tendinitis. And so it really started me questioning if this is a good approach to the hip or not. And I still do direct anteriors as a large number of my workflow for total hip. The newer approach that I do is called an advanced anterior approach. And it takes advantage of the same principles of a direct anterior, with it not cutting any muscles, it's muscle sparing, doing it with the X-ray guidance on a special table, but it takes advantage of that I'm not coming this close to the nerve, and I'm not mobilizing these hip flexors. So what the advanced anterior approach is that you have your abductors, or gluteus medius muscle, and you have your TFL, and in a direct anterior you're coming here and on the inside. On an advanced anterior, you actually come on the posterior border of the TFL, and this brings you in through that layer directly into the hip joint without having to mobilize or retract the hip flexors, and you're further away from the nerve. And this takes you straight down to the hip and doesn't detach any muscles. I have found, and the data has shown this, that it has decreased the rate of hip flexor tendinitis, what patients show up as groin pain, and decreased the rate of numbness around the incision. The other benefit is wound healing problems after a direct anterior, which comes right along the anterior side, can sometimes be in your hip crease. And that hip crease sometimes, because that's how you sit, doesn't want to hill at the top. By coming in a little bit more lateral through this interval, we've also found that the incidence of wound healing problems or need to return to the OR to fix that has gone down greatly. And that's why the advanced anterior is my preferred approach to the hip. Then, to go through the other approaches, there is a direct lateral approach, which cuts this muscle directly in half and spreads it to get down into the hip. I personally think this is one of the least effective ways to get into the hip, because you're detaching the main stabilizer to the hip, and people can have chronic issues here. And so I prefer not to do that unless it's in a revision setting and that approach has already been done. There's another approach called an anterior lateral approach. Rather than taking advantage of this natural interval, the surgeon detaches a third of this muscle intentionally to then open this interval up. He comes in the hip, or she, and then reattaches this tendon with suture anchors. Again, I don't think this approach is ideal for a primary setting, because you're detaching a muscle that, one, causes a limp, and two, is the primary stabilizer of the hip. And then lastly, which is still now the number 2 approach in the United States, direct anterior has taken over, but still 40 to 50% of surgeons in the United States utilize a posterior, which was the gold standard up until a couple of years ago. And in a posterior hip, the posterior muscles that are attached to the femur are taken off, and there's 4 main attachments. And then the surgeon's able to do the whole surgery from the back side of the hip and then repair these back. The problem with that approach is, and I used to do it a lot as my workhorse, is that usually this repair does not heal, which could lead to instability or posterior dislocations, which both of the anterior approaches, both the direct anterior and advanced anterior, have a lower dislocation rate. Those are all the approaches that are the main ones to get into the hip. I hope you understand my rationale behind why I like to use the advanced anterior approach. Talk to your surgeon about which one's best for you, and I'm happy to go over this in clinic as well.